everyone's permission, I'm starting with today's live now. Greetings and a warm welcome to all the dignitaries present here. I am Shwastika from Team Clearnit, serving as the allocated session assistant to ensure a seamless experience. Clearnit is India's most trusted and widely used digital platform, offering a multitude of ensuring services exclusively for the doctors. Clearnit is elected to be chosen as a digital partner for this event. So today's focus would be ophthalmic anesthesia. Now, it is my proud privilege to invite Dr.AL.Meenakshi Sundaram sir. He holds various esteemed degrees such as MBBS, DA, MD, Administrator, Dean and DME in Government Medical College, Theni, Chennai, Stanley. Professor of Anesthesiology, Thanjavur and Tirunelveli Medical College. National Vice President, Indian Society of Anesthesiologists 2016, National Governing Council Members, Indian Society of Anesthesiologists 2009 to 2012, President ISA TamilNadu State Branch 2011 to 2012. State Secretary, Indian Society of Anesthesiologists, Tamil Nadu State Branch 2006 to 2010. So, without any much further delay, sir, I'd like to hand over the session to you. Can you proceed with the session, sir? Over to you.
Thank you very much, Swastika from Clarnat. Now it is my pleasure to welcome you all for this 37th webinar, weekly webinar under the caption Puthukkottai Bhudhan. This is a second edition. 2 years back, we have conducted 52 weekly webinars continuously. And this time we have concluded 36 webinars, and this is the 37th webinar. At the outset, I want to extend my greetings on the eve of Saraswathy Pooja and Vijayadashami, Dasara, Dussehra. I welcome you all for that and extend my greetings. And even the platform ClearNet is operating from Kolkata, West Bengal. And they even requested me, as it is a Durga Puja time, can this webinar be postponed? But I said, see, we have conducted it continuously on every Wednesday. So we cannot skip on that. Even in the previous episode also, even during the festive seasons, we were doing that. But today we are blessed. It is Saraswati Puja because Vidyarambha, the education starts even when they admit their wards in LKG or first standard, they will select this auspicious day. And as it is an educative platform, I don't want to skip. And my special thanks to Swastika for spending her time during this eve of this festive occasion, which is very popular in West Bengal, actually. Even I have conducted this puja, everything by 4 o'clock in two areas, hospital and house. So I'm very happy to be here. And the 36th webinar under the caption Puthukkottai Bhudhan was conducted on 24/9/2025 under the theme of orthopedic anesthesia. The faculty from Ganga Hospital, Coimbatore participated in that. Dr. Reena, Dr. Aparna, and Dr. Stephen Jabaraj participated in that. And Dr. Gurumurthy moderated. He is also from Ganga Hospital. And totally 904 delegates attended it live. Our lowest strength is 821 and nearly 850 people will be attending, and it will be available on YouTube platform also. So many people will be seeing that. And today, the ophthalmic anesthesia, usually I'll take only 5 minutes, but today I wanted to have 3 more minutes as the high-end stalwarts are participating in this ophthalmic anesthesia program. First of all, this webinar is a fifth in succession that each state is having one representative. To have it as a pan-India, just like a pan-India movie, this is a pan-India webinar because Dr. Ranjitha is from Kerala, Dr. Raja Rao is from Telangana, Dr. Jaichandran is from Tamil Nadu, and Dr. Rasesh Diwan is from Gujarat. So that is the success of Puthukkottai Bhudhan. We have conducted it initially 4 programs like this. And today I welcome the pan-Indian stars in ophthalmic anesthesia. And the youngest faculty today will be Dr. Ranjitha from Kerala. Dr. Ranjitha is a second-year postgraduate, and she is from MES Medical College. So she has been donated to us for this webinar by Dr. Shamshad Begum, HOD. So my sincere thanks to her. She is a constant supporter of me, and even she has moderated a webinar on fluid balance in the same Puthukkottai Bhudhan. And Dr. Ranjitha is from Trivandrum. One more state is getting involved now, Maharashtra, because she has studied up to 12th standard in Maharashtra, Pune. Then only she has moved to SUT Medical College, Trivandrum for MBBS. And see, the funniest part is she is very good at drawing and painting. Even I wanted to paint my house, but I cannot hire his art services because she's an artistic painter and she's a good dancer. So we have the violinist Dr. Jaikish here, Dr. Rasesh Diwan, a singer, and I was told Dr. Raja and Rao is also a singer. So Dr. Ranjitha is a dancer. So Dr. Ranjitha is interested in playing basketball during her school days. I think at that time she is taller than all the other students. So then after joining college, she left that basketball and joined badminton and throwball. So she will throw everyone who is coming nearer her. So we have to be very careful. She will anesthetize as well as throw because of her experience in throw ball. Her husband is a radiologist. He is in Malabar Medical College, Kerala. So I welcome Dr. Ranjitha. And the next faculty will be Dr. Rasesh Diwan, who is an international star. Dr. Ranjitha, you should feel happy about you are sharing the platform with the three international faculty. You are the only one from the state and now you are focused to national faculty. Even at the first step itself, you are sharing the platform with the topmost international faculty in ophthalmic anesthesia. So we all should know eyes are only very small area. But in that small area, they are having a vast knowledge. That is what is called as specialization. It is you are going micro level about a broader knowledge about a smaller facility. So these people are really good. Only a pair of eyes are there, but we are having four speakers. And Rasesh Diwan is an international speaker in ophthalmic anesthesia. At present, he is the governing council member of Indian Society of Anesthesiology, which is a prestigious post. And more than that, he is a director, IRCF, that is Resuscitation Council Federation of India. And more than that, he is a past president of Gujarat State ISA, and he is an executive board director, Academy of Traumatology. He is a reviewer of I International Journal. So he is a peer reviewer of that I International Journal, and he is a faculty in World Congress of Ophthalmic Anesthesia. All the three. This is for Dr. Ranjitha and other delegates to note. Such a high-end platform Puthukkottai Bhudhan is delivering, and he is a lifetime achievement awardee of Gujarat State Branch of ISA. I think they have given it early. He is still achieving more and more, but they are so surprised how a person can reach this level. So they have immediately given it to him, and he has been the recipient of West Zone oration called WP Thate oration. So West Zone, then is a state level SK oration also he has delivered. And the most difficult part for any postgraduate is the airway. So he is a chairman of All India Difficulty Airway Association. See, can you imagine a person is holding so many posts and he is organizing chairman for ISACON 2017, that is Gujarat state level conference. Then he was elevated as organizing chairman for the national level conference ISACON 2021. And he, the most honorable post he has received is, he is for 10 years, he was the honorary anesthetist for His Excellency, the Governor of Gujarat, for full 10 years. So we should congratulate him. And he has taken part in all sports level activities in school days. So naturally, for any MBBS graduate, the moment they join MBBS, they will throw away like a throw ball all their extracurricular activities. So he has quit the sports which he loved in the school days, and even after joining the college, he is continued to sing. So he is continued to have the hobby of singing. From the school days he has started. Even now he is doing that, and he is interested in Bollywood songs. So he is hit in a national arena as a singer. So he will be followed by Dr. Raja Narsinga Rao. So Raja Narsinga Rao is a consultant in GVK Emory, Emergency Management and Research Institute. So he is a pediatric anesthesiologist in LVPI Institute in Hyderabad, and he is a president for World Congress of Ophthalmic Anesthesia. So now everybody will know that he is also having an international stature in ophthalmic anesthesia, and he is a treasurer in ITAX, that is Indian Trauma Anesthesia and Critical Care Society, and he is a president of Indian Association of Pediatric Anesthesiologists of Telangana State, and he is a president-elect for Association of Indian Ophthalmic Association. So he is a president-elect, and he is a co-founder and director of Prerna. Prerna is a group practice organization which he has initiated in Hyderabad. Hyderabad is known for the success of that group practice. Even now, throughout the country, Hyderabad is popular for that group practice, which fetches profit for a group of anesthesiologists rather than a single venture. So he is the co-founder and director of that group practice. So when these two international faculties with one would-be international faculty, Dr.Ranjitha, moderation is very difficult. So again, we have to have a stalwart, internationally reputed stalwart. So we have picked up Dr. Jaichandran. And incidentally, we have to note in our Puthukkottai Bhudhan first edition, Dr. Jaichandran participated as a faculty and Dr. Rasesh Diwan was the moderator. Now the ulta has happened. Dr. Rasesh Diwan has become a speaker and Dr. Jaichandran has become a moderator. That means in Scout there is a motto, be always prepared. So anesthesiologist will be always prepared to meet out any challenge. So it is a moderation or a faculty. They both of them can do very well. So Dr. Jaichandran is a senior consultant and a director of Department of Accreditation, Quality and Safety Assurance. See, quality as well as safety assurance in Sankara Nethralaya, Chennai. He is a president of ISA Chennai Metro Branch. See, everybody has become a president of city, state. So that speaks volumes about them. We people are sometimes say we have no time, we have no time. But see, these three people, they have time to take part in all the activities, multivarious, pediatric anesthesia, trauma, anesthesiology, IRCF, so many. So he's ISA Chennai is a metro branch. More than 1,000 people will be there in the member. So he's president of that branch and he is general secretary of World Congress of Anesthesiology, Ophthalmic Anesthesiology. See, World Congress, he is going to take over in 2028. So he is going to be the general secretary for that. And how he has been elevated to that position, he's the founder and secretary of Indian Ophthalmic Association. He has founded, I know how much he has struggled. He was talking to me. I have only seen eyes, not the ophthalmic surgery. So I could not become a member in that, but he was pressurizing everyone. So he has formed with a lot of difficulty. He has founded the association and now he has become a general secretary of World Congress of Anesthesia, Ophthalmic Anesthesia. So I congratulate him personally. And he is president of International Association for Healthcare Data Analytics. So he is doing that also. And he is a government nominated. He is a TamilNadu government nominated governing body member for the Qaide Millat College for Women. So for a women's college, he has been nominated by the government as a general body member and he is a certified professional in patient safety. He is looking after safety in Sankara Nethralaya. He is a certified patient safety manager by Boston's Institute, United States. Actually, near Boston only, that Massachusetts General Hospital is there, where anesthesia was born. Then he has 2 national patent for simulator for regional ophthalmic blocks. So that is a great honor for a Indian. We are happy to have him as a moderator. And he is the chief editor of a book, Principles and Practice of Ophthalmic Anesthesia. So really, we used to say, we love the person like our eyes. So he has written books. He has dedicated his lives for a pair of eyes. So he's a top man in that block and he is an invited speaker. So all these 3 people are invited speakers from the international podium. So Ranjitha, you are going to follow them in that. And with all this great knowledge and endeavor, position, Dr. Jaikish is a great violin player. He's a violin maestro. You can see the Facebook by clicking that. So he will be with the violin only. So such a meticulous job, and I am happy. The previous seminar webinar was on orthopedic, which is a hardware, and now it is ophthalmic, which is a software, and all the people are musicians, singers, dancers. So he's more than that violin. He is a script writer. He is a director. With this introduction, now Dr. Jaichandran is going to direct this ophthalmic webinar. So I have done my part. Please, Jaichandran sir, take it over.
Thank you, sir. Thank you. Thank you for the long and warm introduction. So first, I think we will invite Dr. Ranjitha to have his session, that is lecture on anatomy of orbit for regional ophthalmic anesthesia. Dr. Ranjitha.
Yes, sir. So good evening, everyone, and thank you, sir. Thank you for those kind words. And today we are going to delve into a topic which is very much fundamental and essential to our practice. So, regarding the anatomy of ophthalmic regional blocks, it is very essential in understanding the key structures for safe and effective anesthesia. So coming on to a brief introduction, as ophthalmic surgery has been most commonly performed in developing and developed countries, and there has been a significant shift from the general anesthesia techniques to the regional and to the local anesthetic techniques. So knowing the functional anatomy of eye and orbit is essential for selecting appropriate nerve blocks. They have shown quicker patient rehabilitation and also fewer complications in the patient population. So first coming on to the anatomy of a bony orbit. So the bony orbit, it lies in front of the skull. It is a bony cavity that contains the globe and its associated structures. So in wise of shape, it is a four-sided truncated pyramid with the apex pointing posteriorly and the base facing anteriorly. It has got two medial walls and two lateral walls. As you can see in the image, the two medial wall is also known as the nasal wall. They lie in parallel to each other. Whereas in case of the two lateral wall, which is also known as the temporal wall, they are in perpendicular to each other. In an average, the adult orbit, it contains a volume of around 30 ml, and the apex is where there is the optic foramen and the superior orbital fissure through which the nerves and blood vessels transmit to the eye. The major component of the orbit is the globe, which is commonly known as the eyeball. It is roughly spherical in shape, and in average, the adult volume is around 7 ml. And the axial length, which is the anteroposterior length, in a normal adult, it would be around 24 millimeters. But in case of myopic, these will be having a longer axis, that is more than 26 millimeters. And this is the causing more dangerous during needle blocks because they may cause perforation of the globe and globe structures according. And the other one, in case of hypermetropic, they are having a shorter axis as short as 20 millimeters. Now coming on to the key layers, the layers which are covering the globe is the first one is the fibrous layer, which is having a opaque sclera and transparent cornea. Whereas the second one is the vascular layer, which contains the iris, the choroid, ciliary body, and the choroid. And whereas the third, which is the innermost layer, which is the neural layer, is the pigmented layer, which is the retina. Now coming on to the extraocular muscles and the muscle cone. So the extraocular muscles, they control the globe movement and forms a key anatomy for a landmark for the regional blocks. There are mainly four rectus muscles, including the superior rectus, the medial rectus, inferior and lateral rectus, and also two oblique, which are the two one superior oblique muscle and one inferior oblique muscle. So this is the image of a lateral view of right eye, where we can see the globe within the orbit. This is the base and this is being the apex. So there are the four rectus muscle which has been has follows like superior rectus, medial rectus, lateral and inferior rectus, which is commonly attached posteriorly at the apex of orbit to a common tendinous ring. And there are two oblique muscles, one superior oblique and one inferior oblique. Now, what is a muscle cone? So the muscle cone, the 4 rectus muscle arises from the annulus of Zinn at the orbital apex and run forward to form a cone-like structure. So the space which is inside the cone is called as intraconal space or the retrobulbar space, and the space that lies outside the muscle cone is the extraconal space. The significance here is that there is no intermuscular membrane or septum, so it allows free communication between the intra and the extraconal space. Now coming on to next is Tennant's capsule. So Tennant's capsule, it is a thin membrane which envelopes the globe from the corneal limbus to the optic nerve. So as you can see in the image, this red thickened thin membrane is the Tennant's capsule, and there is a potential space between this Tennant's capsule and sclera, which is known as the subtenon space or also known as episcleral space. So this space is targeted for the subtenons block where the local anesthetic is deposited using a blunt cannula. Now coming on to the nerve supply, mainly first we are going to deal on the sensory supply. So the sensation over the orbit and the globe is primarily by the trigeminal nerve, which is the 5th cranial nerve. And then the major contribution is by the ophthalmic nerve, which is the first and the smallest division of trigeminal nerve. It enters the orbit and further divides into the 3 branches. One is the nasociliary, the other one is the frontal, and last one is the lacrimal. As you can see in the image, the nasociliary nerve, it further branches into long ciliary, posterior ethmoid and anterior ethmoid infratrochlear nerves. And these are the one which supplies the uh, vital structures including the cornea, the ciliary body and the choroid, and also some part of the conjunctiva. Whereas the frontal nerve further divides into supratrochlear and supraorbital nerve. They are the one who supplies the sensation over the upper eyelid, the forehead and the scalp. Whereas the third one, which is the lacrimal nerve, they supply the lacrimal gland and also the conjunctiva. The other contribution is by the second division of the trigeminal nerve, which is known as the maxillary nerve. It supplies the floor of the orbit and also the conjunctiva of the lower eyelid. Next, about the motor innervation. Motor innervation is mainly by the cranial nerves 3, 4 and 6. So the abducer nerve, which is the 6th cranial nerve, it supplies the lateral rectus muscle, whereas the trochlear nerve, which is the 4th cranial nerve, it supplies the superior oblique muscle. And this is the only motor nerve that runs outside the muscle cone. And lastly, the oculomotor nerve, which is the 3rd cranial nerve, that is a major nerve which supplies all the extraocular muscles. So the mnemonic which we often use is LR6 SO4 3. LR is lateral rectus by the 6th cranial nerve LR6, SO4 where the superior oblique by the 4th cranial nerve trochlea, and rest of the extraocular muscle by the 3rd cranial nerve. Now, in case of functional anatomy for surface landmark, we have divided the orbit into 4 quadrants. So, the anterior orbital quadrants are mainly the infratemporal quadrant, which is usually largest and least vascular, and hence it is the preferable site for retrobulbar and for single injection peribulbar blocks. The second one is the infronasal, which is the site for assessing the subtenon space. Other one is the supronasal. Here it is quite vascular and hence it is generally avoided, but it contains the anterior ethmoidal nerve. So it is with cautious used in blocks preferably for the nasal mucosa, like for turbinoplasty and for nasal surgeries. Coming on to vascular supply, the main arterial supply is from the ophthalmic artery, which is the branch of internal carotid artery. The central retinal artery and vein travels with the optic nerve. So, retrobulbar hemorrhage from these arterial or venous puncture is a major and sight-threatening complication of the nerve blocks. So the commonly used regional techniques include the retrobulbar block, which is the also known as the intraconal block, and the other one is the peribulbar, which is outside the cone, which is extraconal, and third critical one is the subtenons block, which is also known as episcleral block, and the last like topical and subconjunctival anesthesia. So, in order to summarize, the 4 rectus muscle form a muscular cone and divides the orbit into intracornal or retrobulbar and extracornal or peribulbar space. And there is third subtenon space, which is the space between the tenons capsule and the sclera. And the aim is to majorly block the ophthalmic nerve, which is the first branch of trigeminal nerve for sensation, and for kinesia, cranial nerves 3, 4, and 6. So, knowledge of this anatomy is essential to effectively anesthetize eye while avoiding injury to vital structures like globe, optic nerve, and the blood vessels. So, these are my references. Thank you.
Thank you, Dr. Ranjitha. Thank you. So that was a wonderful, neat, and elaborate also presentation about the anatomy pertinent to the regional ophthalmic anesthesia. I think we will have the discussion comments in the last. So now we will move on to the second speaker, Dr. Rasesh Diwan. He is going to talk about the various techniques of regional ophthalmic anesthesia. Over to Dr. Rasesh Diwan, please.
Is the presentation seen?
Yes, sir. Please proceed.
Right. Thank you so much, Jay. And offset, I'd like to thank the office bearers of Puthukkottai ISM branch for conducting this wonderful webinars for such a long time. So it's commendable effort. But more than that, it's Dr. Meenakshi Sundaram. Or I feel I don't have enough vocabulary to explain his efforts, what he's making for last 2, 3 years. Is really great effort, and I'm sure it's going to be a national event soon when he takes over the national post for 3 years from coming years. We are so fortunate that you are joining the National Governing Council as a very, very creditable post. And hopefully, I get a chance to work with you also for 2 years. So it's a very pleasurable moment for me. And thank you for a very elaborative introduction also. I'll go straightway to the presentation. Um, I'm so happy that Ranjitha has made my life very easy. She's described the applied anatomy so well. She talks so well that my things have become a little easier now. So basically, when we are talking about regional anesthesia, you must understand what is the requirement. As she's rightly said, it is the pain part which is most important and lack of movement. So we call it akinesia. So this akinesia, abolition of reflexes, analgesia, and complete cessation of sensations are the most important requirement for regional anesthesia, like any other regional anesthesia in the body. So the same principles apply here. So she has already covered a little bit of applied anatomy, which is relevant to the anesthesia in ophthalmic blocks. I'll talk about various techniques, a little bit about local anesthetics, which is common for every blocks in the body, and if time permits, complications about the regional anesthesia. So let us begin. As we know, the requirement is kinesia, anesthesia, and abolition of reflexes. Now, this anatomy she has very well described. This is the orbit. You must imagine when you're giving a block, what is the shape of the orbit. So that is what exactly she described as the conical shape, medial walls and lateral walls. I'm not going in the depth. And you don't need to remember all these bones which form the orbit. It is not for us to remember. It is just the shape which is important and the placement of the structures within the orbit. And these are the structures which are present in the orbit. She already described this, but what I want to explain is the content in a way, how much space they occupy. So this about this content, she said the about approximate volume is 30 ml, but many orbits are variable. Some orbits are large, some orbits are small, some orbits are shallow, some orbits are deep. the depth is more. Sometimes the eyeball is also large, eyeball is small. So in these structures within the orbit, it is the eyeball and the volume of the orbit is measurable. Rest of the structures have a fixed volume. And because the orbital volume is different and size of the eyeball is different, the rest of the things which differs is the connective tissue fat within the orbit. The rest of the structures are same. Now, why this is important is that will help us for the direction of the needle, for the volume we inject. We need to understand the size of the orbit and the size of the eyeball. So among the applied anatomy, these two things are very, very important. Now she showed this slide. It's a wonderful way she described that the orbit is a conical structure, but the medial walls are parallel and lateral walls are angled. Approximately, if you imagine the line, they meet at about 90 degrees. Why this is important is when you enter the needle within the orbit, which becomes a black procedure, the needle when goes from the lateral side has to have this angle. If the needle goes from the medial side, it has to have this angle. For that, the angulation and the orbit angle is very, very important for us to understand. And this is usually fixed, but the content inside is variable, like size of the orbit and volume of the orbit, size of the eyeball and volume of the orbit. Now supply is already spoken. We are concerned with only these nerves, which has a different function. Now optic nerve is purely for the sight, but optic nerve is a very special kind of structure, which I will describe later on, because it is very important to prevent some complication. And the fifth now, the ophthalmic division is the mainly sensory part, which she has already described. So I'm skipping it. Now, important structures, why we need to understand, because we have to relate the needle and the technique of insertion of the needle and injection related to the structures within the orbit. For that reason, it is very, very important that we understand the orbit. We understand the placement of the content of the orbit. We must have the orientation of the eyeball, where eyeball has a parallel visual axis, but the orbital axis are at the angle of about 90 degrees. So these things are very, very important for us to understand where we are going to put the needle within the orbit. And also we need to find out the placement of the ocular muscles, which we are going to paralyze. So all these things are very, very important for us to understand about the anatomy before we actually put the needle inside the orbit. And what are the factors important is if you understand the anatomy, if you understand the variability of anatomy within the orbit, you have to decide the length of the needle, the site of injection, the direction of insertion of the needle, the depth of the needle you put inside, the direction of the bevel of the needle, and amount of volume of local anesthetic we inject. Everything you have to modify according to judging the orbital anatomy, and that differs from individual to individual. Basically, in our armamentarium, we have these many local anesthetic techniques. Now, retrobulbar anesthesia is existing over 75, 80 years, and it has served the ophthalmology so well. But I would say in last about 30, 35 years, it is the peribulbar technique which has taken over retrobulbar technique because of various reasons. The main reasons involve the safety and the quality of local anesthesia. Subtenuous, Ranjitha also described where is the subtenuous capsule and how it is used. It is picking up gradually in last 15, 20 years. It is very widely used in Europe, but less used in India, which is now widely picking up. Very minor surgeries on conjunctiva is done with the subconjunctival infiltration. But topical anesthetic technique in last 25 years is picking up as a great popular technique among the surgeons, particularly for cataract surgeries. And there's an additional facial nerve block which is less utilized nowadays, but was extensively being utilized before 30, 40 years. So these blocks I'm going to describe in brief. Mainly my concentration will be for the peribulbar block. So now retrobulbar and peribulbar, you understand, she also described retrobulbar means behind the globe. The four muscles form a cone, and that cone has a potential space through which the nerves and the vessels are also situated. There is a ganglion situated, and all the structures entering from cranium side into the orbit, they get into this, except the trochlear nerve. So now, when we talk about retrobulbar, that means your needle goes behind the orbit like this. So we need to have a longer needle, and the placement, if you're on the right side figure, you see, if you look from the side, how it looks. In the left side figure from the top, you can see that the orbital axis is perpendicular to the face, but optic nerve is oblique. So this is how you have to orient your needle where it is exactly going. Particularly when you are going in the retrobulbar space, you have to have a longer needle, maybe 1.25 centimeter needle or 1.5 centimeter needle, and you go perpendicular till the equator, and then you divert it to the cone, and you enter the cone, and you gradually deposit the amount, about 1.5 to 2 ml of local anesthetic, which is very adequate for the ocular anesthesia. Now, this technique is very much replaced almost from 1990 by the peribulbar technique. Now, peribulbar itself suggests that the needle is on the side of the eye. It is not going in the retrobulbar area. So, you use a shorter needle, and the tip does not go beyond the posterior pole of the eyeball. Now, let me describe this. Eyeball is anteriorly, there is a cornea. Posteriorly, when the sclera ends, it is known as posterior pole of the eyeball. So the in peribulbar technique, usually the needle does not go beyond the uh, uh, posterior pole of the eyeball. So that is the difference between retrobulbar technique and peribulbar technique. Retrobulbar technique carried higher incidence of local complications like perforation, as well as retrobulbar hemorrhage, and sometimes systemic complication like central spread and brainstem anesthesia. Because of these local and serious complications, though the incidence is not very high, but the magnitude of the problem is so high that it has been almost every places, every centers has been replaced by the peribulbar technique. Now, if I describe the peribulbar technique or retrobulbar technique, you must understand which is the entry point. Now we know the medial side, we call it nasal side, and lateral side, we call it temporal side. And this is the palpable fissure. See, these terminologies you must understand if you are practicing ophthalmic anesthesia. Now, when you want to decide where exactly you want to put the needle, roughly what we do is between 2 points, which are the end points of palpable fissure, we divide them in 4 quadrants. And we imaginarily we draw a line which is the lower margin, the margin of the orbit of the lower side, the inferior margin of the orbit. Now, the junction of the place where we usually select to enter the needle inside the orbit. It's a blind procedure. So we have to orient this place. And this is the place, first we give a local anesthetic about 0.5 ml to produce to a wheel and produce a good skin anesthesia. So that subsequent, when you give the peribulbar or retrobulbar, it becomes a very easy technique and patient is very comfortable. Now, this is the spot normally preferred for a single prick technique with the peribulbar, which is percutaneous. Other spots also are sometimes selected, which I will describe little later. Now, what are the points important? First of all is the length of the needle. If you want to go in the retrobulbar space, you need a 1.5 centimeter needle. But in the peribulbar technique, 7/8 uh, inch or 2.5 centimeter 24 gauge needle is the ideal needle for that purpose. And it should be a sharp needle. Earlier, blunt tip needles were used, but there are studies done on cadaveric eyes that the perforation chances were higher, even with the blunt tip needles than the sharp needles, because with the sharp needles, you have a better control. Some people prefer 25 to 10 or 26 gauge needles, short needles also. But there is a caution for the short needles in a little longer eyeballs, which I'll describe later in some figures I have drawn. So length of the needle is important. Second point is the site of the injection, which I already described. Now, site and the direction of the needle insertion. Now this goes as if you look for the site. The first prick, if you want to do percutaneous, this is the space where you enter the needle inside, and till equator you go perpendicular down. Other sites for injection, normally in my experience, about 85% of the blocks are achieved with one prick only. Other side preferred are the medial one, the near the percutaneous, but near the medial canthus. And third site, which is now being getting popular, is the canthal block. Now, this is the area which is most preferred because there are least vascular structures. There is more connective tissue. The walls, the nasal wall is perpendicular down, is going, is not angulated, and it is very safely. You can deposit any amount of local anesthetic in this area. So these two medial side blocks are very much preferred these days. Earlier, when Davis David described the block, he was giving the superior orbital block also. As Ranjitha also said, this is a dangerous block. There's so much vascularity. And second point is sometimes the orbital roof is such that the eyeball is undermined and you have to take an angle. There are chances of perforation also, and there are chances of hemorrhage also. So we discourage to give this prick in normal peribulbar. But sometimes in some cases, we use when we have to do the, and sometimes I have seen the ENT surgeon also using this block. But for routine surgeries, we don't have to use this block. It's a little dangerous. Then comes the direction of the needle. As I already described, when you are doing an temporal side prick, you have to understand the angle of the lateral wall of the orbit, which is angled. And if you imagine the line posteriorly, it meets at about 90 degrees. So when you enter this, you have to be very careful that you don't hit the bone. It is little painful if you hit the periosteum, and you may even perforate the inferior orbital fixture if you are in the wrong plane. If you are doing a medial block, it is very easy. You can see there is a lot of space around the eyeball, a lot of connective tissue, and it goes just perpendicular to the skin. And irrespective of the direction of the eyeball, if patient rotates, this block is safer in even beginner's hand. So depth is again very important. Depth depends on the axial length. She also mentioned about axial length. Now it is very, very important for ophthalmic anesthetists. Before going the block, you have to check the axial length. Axial length is the distance between the outside of the cornea to inside of the posterior pole of the eyeball. They ophthalmologists measure this for refractive calculation of the lens and refractive errors. For us, it is very important information to judge the length of the eyeball. As she mentioned, 24 is the ideal axial length, but when it is more than 26, 27, 29, 30 sometimes, 32 sometimes, suggests that it is a long eyeball. Now midpoint of the orbit is known as, the eyeball is known as equator. So when this is a very long eyeball, the equator is more posterior. And these are the eyes where more chances of perforation of the globe. That's why it is very important that you understand, you assess what is the axial length of the eyeball. Next important point is the bevel of the needle. You have seen in the picture that in both the needle placement, the bevel is facing towards the sclera. Now, this is very important. If your bevel is facing against the sclera, and if it touches the sclera, there are high chance of perforation. If the bevel is facing this sclera, then if you even inadvertently you touch the sclera, the needle slips over the sclera, and there are less chances of perforation. So this is very important that even if you are using a 24 gauge needle, you must keep the bevel of this needle towards the sclera. And last thing is about the volume you inject. Now, volume actually depends upon whatever amount of connective tissue you have in the orbit. So when you decide how much volume you inject, it is very difficult. You don't have a CT scan of every orbit to judge the volume. So clinically, you have to judge what can be the approximate volume. You don't judge in the milliliters, but you judge it is less, normal, or more. Now that depends on the length of the eyeball, placement of the eyeball, whether it is a deep-seated inside or it is protruding like a hyperthyroid patient. It depends on the size of the palpebral fissure. It depends on the diameters of the orbit. Superior inferior diameter and anterolateral diameter, medial diameter. So diameters will roughly tell you that this orbit is small or this orbit is light. And ultimately, you have to have a clinical judgment to decide the volume you inject within the orbit. Now imagine this is an orbit which is a large orbit with a large palpebral fissure, and somebody, we call it, people have a very large eyes. And you see this figure, even ruthlessly stretching the lid, it does not open much. So these are the people with this small palpebral fissure. We call them small eyes people. They have usually a smaller eyeball. And if you try to fill with your fingers, you find less space between the orbital margin and the eyeball. And you push the eyeball, there's a less movement of the eyeball. So clinically, you try to judge, push the eyeball, how much movement, how much eyeball shifting is there within the orbit. That will tell us that there is a less or more connective tissue within the orbit. More the connective tissue, it takes more volume. Less volume inject in a large orbit, sometimes there is an inadequate block. But in a smaller structure with a smaller orbit, if you try to give lot of volume, there are high chance of complications, lot of rise in intraocular pressure, and it produces oculocardiac reflex. So volume judgment is very important while you inject the drug within the orbit. I have made some drawings and animations, which I'll show you. This is very important. When you give a block, if the patient looks up and inside toward the nasal side, the optic nerve is a very free structure, has a tendency to come down and towards the temporal side. So it can come in the path of the needle, particularly when you are giving a retrobulbar injection. So it is important that we ask the patient to look in a neutral gaze. And a clinical tip I'll give you, the peribulbar or retrobulbar block, we can give standing in front of the patient, facing the patient's face, or you can give standing on the head side of the patient and adjusting the eyeball to the neutral position. My preferred technique is to give the block standing on the head side and adjust the eyeball with your face. Ask the patient to look at your face, look to your eyes, and give a neutral position to the eyeball. And that makes a safety feature for the needle touching the optic nerve. Now, these are some graphics drawings I have made for the peribulbar technique. Imagine your needle goes inside, you inject, you enter perpendicular to the orbital floor, perpendicular to the floor, and when you cross the gradually equator, you turn your needle in the same path. You inject some amount at this stage. In the same path, you withdraw it a little bit. You inject some amount there. And finally, before withdrawal, you inject some amount below the orbicularis oculi. Now, advantage of spreading this drug is at one spot, there is no high pressure. It spreads much better. And when you finally come out, you inject some amount below the orbicularis muscle. It gives a very good orbicularis muscle echinacea. So that's how you avoid the facial nerve in peribulbar technique. Now, this technique for the volume, I want to tell you, you may not hear the voice, but you should be very much in communication with the patient. Now, I have done a small wheel at the right place and given a local anesthetic. And after a few minutes, I go ahead with the actual peribulbar block, which is done absolutely pain-free because the pain is mainly in the skin. Now, what you see is there's a local anesthetic combination drug within the syringe. The marking is in front of my eyes. I am standing on the head side and I am holding the hub of the needle with my thumb and the index finger and start gradually injecting while continuously talking to the patient. You can see the amount of drug which I'm pushing every second. The injection speed is very slow. And this is the time when you see the eyelid is closing. That means you've done enough volume. At that time, you stop and withdraw the needle in the same curved path. The advantage of giving slow injection is the moment the lid closes, you know that there is adequate volume has been injected and I don't overdo. So sometimes I end up at 3 ml, sometimes at 4 ml, sometimes at 5 ml. And in a large orbit with lot of connective tissue, sometimes I even given 6 to 7, 8 ml also. So this technique of watching the eyelid gradually closing, injecting a drug very slowly helps us to judge the volume clinically what is adequate. And with this technique, I have seen almost 80 to 90% of the blocks you achieve 100% echinacea with all the muscles in one prick only. Now, what important things which I have made some graphical designs here is you can imagine this eyeball. Sometimes you have a long eyeball. Sometimes you have a long eyeball which is pushed outside, protruding like an hyperthyroid patient. Will have a lot of connective tissue behind. Sometimes eyeball is placed deep inside the orbit. We call it deep-seated eye, where there is less connective tissue. These eyes take less volume. So these important tips are very important. This is a protruding eyeball. The same way in the other graphics design, you can see long eyeball, short eyeball. This is clinically you judge from the axial length, from the diameters of the orbital opening, from the size of the pupil fissure, and the amount it takes to closing the lids while giving the first prick helps us to judge the volume of drug you inject in the orbit. This is increasing the success rate in peribulbar with single prick technique. Now the same thing can be done with medial canthus block. You give only one prick in the medial canthus after topical drops. The advantage of medial canthus block is it does not penetrate the skin. So the analgesia is not required in the skin. You put the topical drops, you anesthetize the conjunctival space, and opening the eye, you push the needle inside to the medial canthus. It gives a very good safe block with single prick, which is now very modern practice. And I think Jai is practicing it extensively now in all vitreoretinal cases. About Tennant's subtenon's technique, she also described the anatomy that there is a Tennant's capsule which starts about 4 to 5 millimeter from the limbus. Limbus means the junction of cornea and the conjunctiva. So beyond that, about 4 to 5 centimeters, the Tennant's capsule starts. And as she described, we use a curved, flat, blunt tip cannula, which we enter inside, and it goes right up to the posterior pole, and we inject about 3 to 5 ml of local anesthetic inside. And this single technique after topical anesthetics covering the anesthesia for the conjunctiva, you give a very good block. This gives very good echinacea also, so the movement, some paralysis also. However, it doesn't give a full echinacea like retrobulbar or peribulbar block. But this technique is now getting a lot of popularity because you are avoiding a sharp needle within the orbit, and there are less systemic complications also along with this technique. And it is a very preferred technique nowadays in cataract surgeons and glaucoma surgeons who are not performing under topical anesthetic technique. So I'll show you one video of this. Is the video running? Now,
Yes, sir.
subtenance
Yes. Yes.
is actually a minor surgical technique we do with proper topical anesthetic applied 5 minutes before, and you open the conjunctiva and the Tennant's capsule with a scissor. And this is the blunt tip cannula. You put it inside, and it's gently when you introduce, it goes in the Tennant's capsule and takes the curve of the eyeball right inside, and gradually you inject 3 to 4 centimeter of milliliter of local anesthetic. And the eyeball starts coming little in front because of it becomes full with the this technique is less popular now, still in our country. It involves minor surgery, so it is not been taken over well by anesthesiologists in our country. So many places when the surgeons do this technique, they do it themselves. But I know Dr. Jai is doing a lot of workshop on this and has started propagating it so well in the last 10 years that probably another 7 years in major ophthalmic institutions, anesthetics will take over this technique also because there is a lot of safety margin. We are avoiding this sharp needle. Facial nerve block is something which is less being utilized now, was done to paralyze the orbicularis oculi muscle because we have to paralyze this muscle Otherwise, patient starts squeezing when the surgery is going on, which raises the intraocular pressure. And three techniques were suggested. Nut bath technique, you can see with the red dot, which is near the steroid process, but not very popular. O'Brien technique was the most popular technique used in the world, which is at the angle of the mandible. When you open the mouth, this is special technique to do it, and it is little painful, but it gives very good hemi facial paralysis. And last one is very popular among ophthalmologists is the fondling technique, which is given to the final nerve fibers of facial nerve, which are entering the orbicularis oculi muscle, and it gives a very good lead echinacea. Sometimes this technique is used to supplement when longer surgery is there and patient has a facial block in peribulbar where. So surgeon additionally do this to paralyze the orbicularis oculi muscle to prevent the squeezing of leads over the surgical site. So this is a facial nerve block which is less being utilized nowadays. Now, topical anesthetic technique is picking up a lot now among the cataract surgeons because there are no injections, no trauma, no patch or shield on the post-operatively. Patient go out of the theater without patch, no waiting time. In few minutes, it works and can be supplemented any number of times and can be repeated even during surgery also if the surgery lasts more than 10, 15, 20 minutes. There's a lot of acceptance by the patients and the surgeon these days. However, the limitations are eyeball is moving, is not paralyzed. So we have to keep on telling the patient sometimes to look at the light, stabilize your eyeball, and the leads are not paralyzed. So ask them to keep it widely open and to. So we need a lot of counseling to be done before we do the topical anesthetic technique. This is supplemented by very commonly by some IV sedation, which I've been extensively using it. This is preferred technique for phacoemulsification technique only. The conventional cataract surgery, this technique is not preferred. Now, this can be done with 4% topical lignocaine, 2% lignocaine, preservative-free, tetracaine, but most common drug used these days is the proparacaine because it is more patient-friendly, does not give any stinging or burning to the conjunctiva when you apply. We extensively use 2% preservative-free lignocaine gel, but nowadays this gel is not available. Addition to the topical anesthetics, 1% preservative-free lignocaine is the drug used extensively for cataract surgery after making a nick in the conjunctival in the anterior chamber. And this gives an additional anesthesia. Usually, this is done by the surgeon. Local anesthetic combinations all are same like any other block. Only I want to mention is the hyaluronidase, which is the drug which is a spreading factor, an enzyme which is used preferred only for ophthalmic blocks and been extensively being used for more than 50, 70 years. This helps because particularly in the peribulbar technique, in all other blocks in the body, you inject right in the vicinity of the nerve. But in peribulbar technique, you are injecting in the connective tissue and you want the drug to travel from the drug you deposit to the target neural tissues. For that, you need a spreading factor, and hyaluronidase is very extensively being used in ophthalmology. Now, do I have the time to talk about some complications, Dr. Jai? I talked about the techniques, which is useful for the postgraduate students. I'll briefly talk about complications.
Max, another 3 to 5 minutes, sir.
All right, thank you so much. So now try to understand. Eye is a part of the brain. It is always covered with the meningeal layers extending from the cranium over the optic nerve. So the optic nerve sheath is continuous extension of subdural and subarachnoid space. So like epidural, if you do a prick in this, you are in the retrobulbar technique particularly, you are very close to subdural or subarachnoid space. So this is an extension of meningeal layers from the orbital foramen. The blood supply and orbital content is through the central nerve. Blood supply and nerve supply is from the central nervous system area, and it is supplied by the autonomic nerve supply. So these are the factors which makes it more vulnerable to systemic complications. And for that, we have to understand the correct technique. and identification of such complications. And one of them, serious complication, which is a common question in postgraduate students, is the oculocardiac reflex. I think we can cover it next time. These are the ocular and systemic complications, the local complications and systemic complications. Ocular complications are the globe perforation, which is very much technique dependent, and more chances are there when the eyeball is long. In very myopic eyes, where the length of the eyeball is more, when the axial length is more than 26, 27 millimeter, there are high chances of perforation. And very high myopic eyeballs have sometimes staphyloma, which has a very thin sclera, which you cannot even not detect also perforation. Retrobulbar hemorrhage and peribulbar hemorrhage are so local complication, and injury to the optic nerve and other nerves and muscles is local complication. While systemic complications are very serious, intraarterial injection in the optic artery can cause convulsions and cardiopulmonary arrest. Optic nerve sheath injection can cause brain stem anesthesia like total total spinal anesthesia when drug goes in the cranium. And oculocardiac reflex is just because of the pulling of the muscle or too much volume injected very fast within the orbit. If you are not very careful, can cause severe pericardia, arrhythmias, and asystole even while injecting the drug in the orbit. We are not describing its complication, identification, and management, but you must understand the local complications are retrobulbar hemorrhage, low perforation, optic nerve injury, and on long term can cause ptosis and diplopia because of the ocular muscle injuries. While systemic complications are because of the spread of the drug inside can cause subarachnoid spread, brainstem anesthesia, oculocardiac reflex, contralateral hemorrhages. Suppose the drug does not go subarachnoid but goes subdural, can go to the optic chiasma, which is the junction of two optic nerves, and can block the opposite side optic nerve and produce blindness in that eyes. That is known as contralateral hemorrhages. You give the block on the right side, and the left side patient loses the vision. That is a temporary phenomenon. You have to reassure the individual, and it recovers after automatically after the block wears off completely. So these are the complications which we must keep it in mind. And for that reason, it is very, very important that you understand the anatomy. So, Ranjitha, your lecture was the most important lecture. Now, every time you understand, when you give a local block, when you are doing under the monitored anesthesia care, it is very important that you do good preoperative counseling during the process. You must have an IV line press. You use a judicious sedation. I usually prefer fentanyl before giving the blocks. And even now in topical anesthetic technique also, you must be in a continuous communication while you are giving the block, and you must have a standard monitoring device. Imaging, you are on the table and I'm about to poke the needle in your orbit. How much fear you have. You are seeing me like this. I'm standing on your head. You have a fear of losing vision, you have fear of pain, you have fear of unknown origin, like what will happen, and a needle is coming to your eyeball. That's a very, very fearful condition, and you must counsel and do judicious sedation to this patient before you give the block. So, if I summarize the orientation of anatomy, which was taken care by Ranjitha so well, helped me out to continue my lecture, is very, very important. Needle blocks, when you are doing, inject very slowly, considering the volume you want to inject, the necessity of the deciding the volume of the drug you want to inject, and oculocardiac reflex. Keep talking to the patient continuously, so that's a very good monitor, and watch for systemic complications, which are very rare. But the complication which happens in an ophthalmic theater carry very high magnitude of the problem. So with that, I would like to end my presentation, and later on we'll take the questions. Thank you so much.
Thank you, Dr. Rasesh. That was a wonderful presentation. You have clearly elaborated the different techniques, talking in detail about the minute points also. So moving on to
Jai, I apologize for my quality of voice, because since yesterday I was suffering with very bad throat.
No problem.
In morning
But
I was
it was
thinking
clear only, sir.
in morning I was thinking I won't be able to speak also. But
No.
with 2-3 lozenges and hot water, it improved
Yeah.
little bit in the evening.
Yeah, no
Thank you
problem. It
so
was
much.
clear. And yeah. Now moving on to the next speaker, Dr. Venkat Raja Hadigal. He is going to talk on anesthesia for ocular trauma. Over to Dr. Raja, please.
Good evening to one and all. Thank you, Dr. Meenakshi Sheshadri Garu, for giving such a nice words about all of us. And I'm very happy and I'm privileged to be among the stalwarts of ophthalmic anesthesia. Dr. Jai was the one who you can call him as a father of ophthalmic anesthesia, especially in India. He has started that forum. And Dr. Rasesh Diwan is also one of the prime ophthalmic anesthetists. And I still remember people saying that I work at LV Prasad and I started my career in LV Prasad from 1999. And it was said that before that, Dr. Ashish was the one who came and started peribulbar blocks, training the people over there when they give the block. So I'm very happy. And when Jay told me to talk about this ocular trauma, I was very happy to take that because I was literally, in fact, actually, we are in our center, we are seeing that there are a lot of ocular trauma patients where they are reaching very late to the institute. So, since LV Prasad is a very pioneer and very standard institute, they want to bring some system where the trauma patients, especially the ocular trauma patients, are brought at the right time to the right care of that patient. So when Dr. Jay told me to talk about that, I was very happy to take that topic. So just I'll give you a brief study that was done very recently in LV Prasad Eye Institute. So this is a data which is about almost about 10 years. 1,15,390 cases were there. Open globe injury was 1,06,000, and the other out of which 67,230 are at the tertiary centers, and 39,433 are at the secondary centers. And of course, we have the closed globe injury also in this. Now, next, coming to the number of, to see whether what is the number of patients who are there. I'm sorry, I'm not able to. I think I'm not able to see my screen, Jay.
You're able to see, sir?
You are able to see, but I am not
Yeah.
able to see. I don't know what happened.
You just
Okay. Let me.
click that zoom icon. You click that
Okay.
zoom icon.
Yeah. Okay. Now I'm able to see. So when you see that these patients in the last 2024, are you able to see the screen?
Yes, sir.
Dr.
Yes, sir.
J.
Please proceed.
Yeah.
Yeah, please proceed.
Yeah. So we're almost every year we are seeing that there is increasing amount of ocular trauma patients, and if you can see just only in 2020 during the COVID time where the number shortage of patients were there. But if you see the other components, we have seen that there are a lot of patients of ocular trauma over there. And 15,000 patients are there in the last year, 2024. I'm not able to.
What happened, sir?
I'll stop share screen and again take because I'm not able to see that. Are you able to see the screen now?
No, sir.
No?
Start sharing. Start sharing.
No, are you able to see the screen or not?
No, we are not able to see. Once again, you start sharing, sir.
Now?
Yeah.
Okay.
Yeah. You start. No, you press that. Yeah. Now full
Okay.
view. Full view.
Okay.
Full view. Yeah.
Okay. Now, if you see the
Yeah.
gender, The male gender is almost about 90,000 of that, and 20,000 are the female genders of this particular. Now, the total surgeries performed in these patients are 16,000, and out of that, you can see the diagram where the corneal tear repairs are 42% of that are the corneal tear, followed by scleral tear and other emergencies. Now, why I wanted to specifically focus on this particular ocular trauma and my interest was, if the ocular injuries are not treated in the window time, then there is a high chances of vision loss. That is the window time, what the ophthalmologist and the everybody say that it is a 24 hours period. If the surgery, suppose the time of injury and the knife on the eye is not within the 24 hours, there is a high chances that the patient may land up in end up. So many dedicated ophthalmic institutes are starting services so that the patient can reach the OR in the appropriate time and proper care can be taken to the patients. So services for this should be given in many ways, starting like if any organization or any definitive care ophthalmic institute say that we want to operate in time, but we have to create awareness in the society. We have to create awareness. You have to develop a lot of things in that. You have to have if you have a dedicated call center where they can receive the patient, where they can monitor the patients and send to the appropriate institute, that will be a very good outcome for the patient. If the patient reaches in time for surgery, and even the preparedness at the center where the patient is going should also be there. So once the trauma patient reaches the hospital, the primary care physician should examine. The main purpose I just wanted to tell about the basic primary survey and secondary survey, and how shortened we can make this primary survey and secondary survey, doing a head-to-toe examination, especially in this physician, or if it is an ophthalmologist also, if a trauma patient comes, how we have to examine. That is the one I wanted to focus on. Once a trauma patient reaches the hospital, the primary care physician should examine that and should also be able to patient, and other systemic involvement is there or not, he should be able to evaluate. So as I said, again, I'm repeating, the window period is the injury to the, from the time of injury to the knife on the eye or the surgery that is done is 24 hours. If it crosses more than that, then the chances of end-op is more. Now, I just wanted to give brief about our statistics in LV Prasad. The average time for a trauma patient to be present in the hospital, what they have done the studies, they have found out that it is more than 4 days. You see, the trauma is occurred somewhere, they went to one hospital, they are shifted the hospital to other place, and then they found out that there is nothing, there is no chest injury, there is no abdominal injury, no internal bleeding, and then again they sent to the ophthalmic institute. So it is a 4 days period that. So, and the other thing what we noticed is, from their check in the surgery, the start time is 70. Once they check in, even also there is a lot of delay. There is a 17 hours delay after the patient checks in. So that is a very, very long period. I'm not saying specifically in LV Prasad, but in regularly in most of the hospitals. And this delay is why it is happening. This delay is they are not able to, like patient comes there and then they have some examination has to be done. Sometimes they have to take an opinion of the neurosurgeons, a neurophysician, a chest physician, a chest trauma surgeon and all. So that is it is taking a long time period. And what we feel that once the patient checks in, the surgery should be done within a 4 to 5 hours period. So now I just brief about the different type of training that is there, which I feel that after seeing all these things, I feel that even a physician or a anesthetist definitely has to go through this training programs. And apart from that, even a ophthalmologist who is dedicated to trauma surgery should also have this type. One is the ATLS, Advanced Trauma Life Support. It is in collaboration with US, where we have started our ATLS programs in India, and many places are taking this particular program. And the other one, and why I'm mentioning these particular programs is every life support, trauma life support training programs have their own type of doing a primary survey. ATLS have the system of doing ABCDA, airway, breathing, circulation, disability, and exposure. ITLS also, ITLS is International Trauma Life Support, and we train, I work apart from LV Prasad Institute, I'm also I also work with the EMS 108 services, which is one of the largest emergency service provider in the country. And we find a lot of trauma patients which are being shifted in our ambulances. So we trained our EMT, the emergency EMT, the person who takes care of the patient, who reaches the patient to the site of ITLS. ITLS is a pre-hospital trauma life support training. And here they do the airway, breathing, circulation, followed by head to toe examination. What I felt that this ITLS pattern can be learned by every physician, so that once a patient of trauma comes, they can easily examine the patient from head to toe and find out whether there is any systemic involvements there or not. There are other training programs also, like CTLS and all, which are. So the initial assessment and management, if you take the primary survey, it is ABCDE with immediate resuscitation of the patient. So now just let me speak about now a patient, a road traffic accident patient has come to you, and here the patient is having, first of all, you see the level of consciousness. If the patient is unconscious, then you go for the BLS sequence, code blue, and all those things. But if the patient is semi-conscious and if he's having a injury anyway, any part of the body, then you have to do this primary survey, checking up the airway, breathing, circulation, and all. And there are a lot of adjuvants that are needed in the primary survey. And just in my next slides, I may be presenting those things. And consideration of the need for the patient transfer. We have to just evaluate him very fast and see whether he needs any transfer to any center, any specialized definitive care center, neurosurgeon, or any X-ray, something like that. And then the secondary, if the primary survey is evaluated, then you go for a head-to-toe evaluation, and you can take the patient history, and definitive care can be taken. So as I said, consciousness or not, how to know the consciousness or not, we all know there are two scales. One is the AVPU scale, alert, verbal, painful state, responding to painful state when unconscious. Another is the Glasgow coma scale is there, where especially our anesthesia critical care people who follow the Glasgow coma scale. So in the ABC CES of the trauma patient, identify the life-threatening condition, and then A is for airway, maintaining with, first of all, in a trauma patient, like ABC, RCS, even in any patient, a trauma patient, once it comes, if you go for the BLS sequence, it is CAB. But in trauma patient, there are two C's and followed by CAB. So the one C is for chest compression and or circulation, and the other C is for cervical immobilization. So that is an important component where a trauma patient has to be taken. If you don't have a device to immobilize the cervical collar, you can do like with your hands, you can also immobilize the patient and then go for the survey. So airway maintenance with the restriction of the cervical spine motion, breathing and ventilation has to be taken, circulation with hemorrhage control, disability, and this is the primary survey. So this is just a flow chart. What I wanted to go is, can the patient talk normally? Yes, airway is open, continue ABC. If the patient is not able to talk, can the patient to walk, then can the patient talk or talk at all, and then follow that sequence, like look, listen, and feel. Many people, they'll follow this, but in trauma patient, we suggest for inspection, palpation, and percussion. So coming to, once a patient has come, a trauma patient, they might have referred from some institute that he is having an ocular trauma, but every patient has to be re-evaluated at your center by your physician or the ophthalmologist himself or in-house anesthetist has to reevaluate it before they post them for a surgery. So the first of the thing is you do immobilization of the cervical collar and then go for the see whether the to examining the chest. Like first of all, see the trachea whether it is central, and then see any injuries are there over the chest and all. But before seeing this, definitely you have to see whether any injuries are there on the face and all. And coming to the chest and all, see whether any injuries are there on the chest and inspect palpation purpose. Now just put a photograph. If at all, normally we advise not our EMTs, but physicians who come for this training and all, we advise that if at all you feel that the patient is having a pneumothorax and you don't have the facility, it may not be, it may be a low resource setting and they may not have you need not wait for the sending the patient for X-ray and all, but you can just put a needle, you can needle decompression, and then you can uh, treat the patient accordingly at that particular time. So what these surveys, whatever it is, whether it is ATLS or ITLS, they say that inspect, then immediately you act. Like suppose if there is a pneumothorax, then you have to put a needle decompression. And sometimes there may be massive hemothorax, rapid accumulation of almost more than 1500 cc of blood in the pleural cavity. That has to be there. But of course, I don't say that a patient who is coming with this type to our ophthalmic institute, you should manage. But just I'm telling what are the things you should be saying. The chest tube can be also inserted. Um, then some wounds are there where there is a caused by penetrating chest injury. These wounds can be easily taken care by putting just a what you call a flap, so that the air entry from outside is not there. But you can see three-way occlusion dressing, we call it as, may use as a plastic wrap to the patient. So sometimes we have always, whenever you have a fracture of the ribs, definitely look for any abdominal injuries or liver lacerations and all. And of course, pneumothorax or hemothorax on the side of the patient, on the same side and all. And if the fracture of the ribs are on the left side, definitely look for this. Most of them, many of the times, there may be a splenic rupture. So all these things have to be taken care and during your examination of the patient. There may be pericardial tamponade, and I don't want to go into the detail, and our cardiac tamponade. So what I'm trying to tell you, suppose if you have a patient who has come, suppose near to your hospital, definitely when there is a hospital wherein you, even though they don't see whether it's an ophthalmic hospital or directly they may bring your patient. So this type of survey can be done. Suppose a patient is having a severe bleed, you can just stop the bleed by tying a bandage. And we do some programs where we teach the auto rickshaw people, the drivers, the police people and all, how to stop the bleeding. We developed some kits in our EMRI 108 services where, and many people have done those skills and were able to save the patients. Now, for disability and neurological, when you come to the head, you can have this type of injuries where the patient may be having some intracranial injury. And if you see this type of patient, definitely you need not, I'm not recommending to take him for ophthalmic surgeries and all. Definitely you have to re-evaluate it and re-evaluate it. And of course, after seeing the chest, you have to go to the abdomen, examine the abdomen, and then see whether any injuries or any internal bleeding is there. Then when you go to the pelvis, many of the times it so happens there may be a pelvic injury. And if you feel that, if the patient feels that he is having any pain in the pelvic region and all, you can just uh, put a what is something like a bed sheet or something, and then tie a knot, so that that injury or that bleed, if he's having any bleeding also, that can also be controlled. And if you're going down to the lower limbs, he may be having a fracture and all. So you have to put some splints and tie a bandage and all. And of course, you have to see the pulsation, the lower limb pulsations and all. And the most important thing what I advise in this type of survey is always many of them we forget to see the back and all. We have to do log rolling, 3 people, one holding the neck, the other person putting the 2 hands over the side of the chest, side of the abdomen and all, and the third person over the leg, and slowly move the patient to one side, and then with all the 3 people should with a rhythm they should move the patient, because one moving the head in one time, another should not be there, like counting 1 2 3 and then moving the patient, and just examine the back from top to from head to toe, at the back side, the spine and all. Many of them, it so happens, it has happened many times that they examined the front part of the body and they forgot, and afterwards they found out there was injury over the back. So we have to examine the back also. So all these injuries, I'm just showing the pictures, like suppose a patient is having a um, what you call rhinuria, a bleeding from the ear, any type injury can come in. I'm not recommending you to take that type of patient for surgery, but definitely you can evaluate, and we can take the opinion of the neurosurgeon if he's there in the hospital, or if you don't have, you can send it to a higher center, and then but if you feel that after examining the head to toe and we feel that the patient is not having any complicated things and in no other systemic involvement are there, then he need not be again diverted back to other specialist or trauma specialist to reevaluate them and then take him for surgery. So this is the rough traumas that Glasgow trauma scale what I have just written. And once you come to the disability management, if unequal peoples are there, and all those things have to be seen to the patient. If the peoples are equal on both the sides, any signs of any increased intracranial pressure are there, all those things have to be taken care. So this is my just brief description of how you have to how you have to examine the patient, assessing and simultaneously managing. So my goal of telling all these things is, when this type of patients come to you, since the window period is very short, like starting from injury to the surgery is 24 hours, if he might have gone for one hospital. So try to not waste much time in the making the patient go around here and there. And if he doesn't have any systemic involvement, you can evaluate. We are all first physicians and then a specialist. He may be an ophthalmologist, he may be a physician, he may be anesthesiologist, whoever it may be, and systemic involvement. See for any systemic involvement is there. If there is no systemic involvement, they can recommend the patient to for surgery. Now the anesthesia components and all, because there are many anesthesia, most of them are anesthesia people. So these are the adjuvants what anybody may need. One is a chest X-ray, then fast. Many of the institutes, they may be having an ultrasonogram, they can do the fast. ABG can be sent, ECG. I think most of the institutes, they have this equipment. Maybe X-ray must also be there with them. And if you feel that the patient is having any pelvic pain and abdominal pain, better to put a Foley's catheter, and then Ryle's tube decompression. The stomach can also be done. Most of the trauma patients, they have delayed emptying of the stomach, so better to. Now the question here arises when we talk with the ophthalmologist and the anesthetist about the NBM. And we have heard about all the things what they have told about the window period and all. Taking into window period and all, what we say, what all of them are anesthesia. What has to be done is, if suppose the patient is not on NBM and is a threat to the eye. Now, for example, if you get a patient of fetal distress, you don't say that I don't want to anesthetize this patient because there is no the patient is not an NBM. In a similar way, this type of patients, if they come and there is a threat to the eye, if the surgery cannot be done, so then at that particular time, I think NBM need not. You have to take your own precautions. The anesthetist have to take his own precaution with taking high risk consent. He had to put a tube, stomach tube, and empty it, and then rapid sequence induction can be done. So that was the point which I want to bring to the notice of many of the stalwarts or the anesthetists or the critical care specialist, ophthalmic anesthetists may be there in this forum. So what I just wanted to tell you one abbreviation where normally our EMTs, the basic people who are just not a physicians and all, but they follow this DCAP BTLS, a medical mnemonic, particularly used in the pre-hospital emergency care. And this helps to assess a patient for signs of trauma during a physical examination. The acronym stands for deformity, contusion, abbreviation, it may be penetration or puncture, burns, tenderness, laceration, swelling. So in each of their inspection and palpation, if they follow this, they won't miss any of the patients. So these are some of the things which I wanted to tell. And so what we thought is, one is the anesthetic management. Like anesthetic management, I need not mention anybody. Like so the medications, the induction agents are the agents which increase the intraocular pressure should be avoided, like ketamine and all. They can induce by the normal induction agents like propofol and all, maybe thio, sodium pentothal and all. Fentanyl can be also be used, and muscle relaxant. Scoline is better avoided. We all normally in ophthalmic institute, we don't use scoline at all. We can long-acting muscle relaxant and all. And definitely you should be well prepared for rapid sequence induction and also other like fibro optic and all the things have to be ready, especially in the institutes where anesthetists are there. Many of the institutes, they have all this equipment, but many of the standard institute, they have this equipment. I don't say the other institute doesn't have, but it's better to have all this equipment well prepared so that we should not be any problem while induction and intubation of this particular patients. I think I'm before time. I didn't take much time to sell, and I'm looking for some more of questions rather than me telling about all these things, because these are the basic things. Everybody know the head to toe examination. Everybody know the primary survey. Everybody know the secondary survey. And why one thing I just wanted to bring to the notice of everyone is many people, they overlook all these things. They don't think that it is not our domain, even anesthetist or a critical care persons and all. But I feel that the anesthetist and all, if they can take all these resuscitation programs, like ACLS is a mandatory, and I feel that people working in a specialized tertiary care centers who have a lot of patients and all, it is better to have take this ATLS and if they think that they get a lot of trauma patients, better to have take ATLS center. We have a ATLS center in Hyderabad in EMRI. Of course, I know in many of the centers, many of the cities it is there. So I am also ATLS trained and ITLS trained. So I see many of the people who are coming are emergency medicine people or critical care people. Apart from that, hardly we see a handful of orthopedic and surgeons who come for this type of course. So I feel that all these trauma surgeons should also definitely take this type of training program that will be added value during their practice and during their when they do the practice or when they're working in the theaters and all. It will be a very useful thing for that.
Thank you,
I
Doctor.
just end my talk, Jay.
Yeah.
Just I end my talk with
Stop sharing,
one of the
sir.
examples I wanted to give.
No, you should stop sharing that one. Screen share, stop.
Okay.
Yeah.
So I just wanted to give very recently, some of my colleagues may also be attending this particular sessions. Recently, we had a patient sent from some institute with ocular trauma. And very rightly, the physician saw that patient, and the patient had a injury on the right side, and he had a little bit of perforation, and our anesthetist saw that, and even in the X-ray they have shown that there is some leak in the right side of the chest, but still that patient was recommended by many of the people to take the patient in general anesthesia. But our anesthetist rightly pointed out that it can be taken under local, but I'm sorry, it can be taken under block. You can do a peribulbar block and do it, but we cannot do it under general anesthesia, because even we can put when you put an endotracheal tube, even though this perforation which is there in the chest is a very small size, there may be little leakage. After the intubation, the size, if the size increases more than the this endotracheal tube size, definitely there will be disaster. So we told that if at all we want to take that case, we'll take under chest tube incision, after chest tube incision. But very rightly, our anesthetist, Dr. Ramakrishna and all were there, who told that it has to be taken under block, and the ophthalmologist agreed, and they have done that. And so I'm just telling you the example
Yeah,
about the
okay.
things that may
But we are
happen.
running short of time. So there are few questions from the audience delegates. So the one question is whether you or your surgeon blocks when it is retrobulbar or peribulbar. So normally nowadays it is the anesthetist who is going to block the case, especially if it is a needle block. Subtenous blocks, as Dr. Rasesh was mentioning, it is little bit of semi-invasive procedure. Many in Indian scenario, I mean, many of the surgeons are preferring, whereas outside India, it is mainly the anesthetist who does this subtenous blocks in the preoperative area itself. Maybe it will take another 5 years down the line to get this subtenous block fully established in Indian scenario. Next question is, what is the most dangerous complications you have encountered in your experience and how it was managed? I think complications part, Dr. Rasesh Diwan has clearly explained. So it has to be managed symptomatically only. Okay, if it is a brainstem anesthesia, Dr. Rasesh has clearly mentioned that we have to monitor the patient, provide oxygen. If there is a fall in BP, then give the IV fluid. So symptomatically, you have to manage those patients until the local anesthetics effects wears off. Yes, Dr. Rasesh, please.
Yeah, very nice. You explained and gave the answer to this question. The question is which you have encountered in your experience. My experience of giving blocks over lax patient, the worst I've ever seen is my early practice when I was injecting the drug in a very small orbit. I was like faster, and he had a severe oculocardiac reflex. Heart rate went down to 40, and the
Oh,
blood pressure also dropped. That is the worst complication I have ever seen. That's why
oh,
I'm very, very
okay.
skeptically teaching people for the volume. Don't overdo with the volume. Do it very slow injection, and I had a very tough time to recover him. Fortunately, hemodynamically, he became stable in another 4 5 minutes. But and that situation, giving atropine is also dangerous when
Yeah,
there's an acute active oculocardiac reflex. So I kept it ready. I connected it. I kept adrenaline ready and everything. In 3 4 minutes, he started recovering, and then I gave the atropine, and the heart rate recovered. After 10 minutes or so, when he had settled down, he had already had good block because I had already injected little extra volume. So that's
yeah.
the worst thing I've seen. But oculocardiac I have seen more frequently than any of the serious complications, which are very rare actually. But oculocardiac is the one you have to be very careful in
Okay.
ophthalmic practice.
Excuse me, sir. Oculocortic reflex can happen even while injecting local anesthesia, is it? Not during surgical
Yes,
manipulation.
yes.
It is
Yeah,
mainly
it's
pains.
one is what we are commonly describing is the pulling of the particularly medial rectus muscle, and that is very frequent even in squint surgeries, even under general anesthesia. But while giving peribulbar block, sometimes vasovagal is common, but more than when you are injecting the drug, and if you are doing very fast injection and the orbital capacity is not there, any 1 or 2 ml of extra drug can cause a lot of pressure over the eyeball and is a common cause of oculocardiac reflex. The
Okay.
incidence is not very high, but the
Yeah.
magnitude of the problem is very high. It is very difficult to treat sometimes. Because
Okay.
in a muscle pull, you release the muscle, you inject local anesthetic in the area, and you get rid of it. But here you have injected the drug inside the orbit, which is very difficult to take out. So that's the most dangerous complication in my experience I have seen.
Thank
Sir,
you.
in
Doctor,
retrobulbar block, moderator, sir, in
Hmm.
retrobulbar block, if there is a proptosis of eye, because you are talking about volume and the space, if there is proptosis of eye, whether you will abandon the procedure or you will wait and you will go ahead with the procedure, just like cataract.
See, sir, so the proptosis, the retrobulbar main thing is slight proptosis. Okay, sir, you can give digital massage and go ahead. So the other thing is we should be very clear when hemorrhages has happened in retrobulbar, it is quite common sometimes to have a retrobulbar hemorrhage. Now, this
Yes.
hemorrhage is of two types. One is venous, other is arterial. If it is a venous type, it will be a slow in onset and mostly it will settle with the digital massage. But if it is an arterial bleed, then definitely you have to, surgeon's intervention is required. Sometimes they give that anti-intraocular pressure dropping medicines, Diamox, mannitol, tight massage and patch. And sometimes they have to defer the surgery also. So there are two types. We need to differ whether it is a venous hemorrhage or arterial hemorrhage, then take the decision, sir.
But the arterial hemorrhage doesn't require any exploration.
No, no. Sometimes, no, if there is a compartmental syndrome like thing, say for example,
Yes.
too much bleeding happens, compartmental syndrome as occurs, and retinal surgeons they come and see under indirect. If the retinal disc is completely pale, that means ischemia has already set in. In that scenario, they have to do an emergency lateral canthotomy.
Yes.
Yeah. Okay, sir.
They they normally do lateral canthotomy
Yeah.
and open up and release the hemorrhage. And
Yeah.
nowadays we get the immediate consultation of a retinal surgeon to evaluate the fundus as well as ultrasound also.
Yeah.
There is a question on ultrasound
Yeah. Yeah. The
also.
next question, moving on to next question. If it is an inadequate block, how will you manage repeat block or general anesthesia?
Right.
First and foremost, before handing over the case to the surgeon, make sure that eye has attained complete analgesia and echinacea. You should make sure that complete analgesia has happened. Okay. So one thing what we can commonly do is you put that apidin drops over the eye. Okay. If there is no stinging sensation by the patient, then it is ensured that there is complete analgesia. Sometimes to be more objective, you can even hold the conjunctival holding forceps and hold and see that all the four quadrants whether the block has taken. Okay. Now, suppose unfortunately the surgery is prolonged and if the patient is complains pain in between, if it is a retinal surgeon, very well, the conjunctiva will be already opened. We can request the surgeons to give a supplement with the subtenons block. Okay. So it is very, very rare thing to go with general anesthesia due to inadequate block. But there are very rare instances, say, for example, patients becoming uncooperative, claustrophobic. We might need some IV sedation, supplementation, and then we need to proceed with the case. Anything, sir? Dr. Rasesh, you want to add upon?
Yes. You rightly said, first of all, you need to submit the surgery to the patient to the surgeon only when you are satisfied. So, peribulbar technique when you are doing, and in my experience, about 80-85% you get one trick only. But if you find there is inadequate akinesia, means middle rectus is moving or superior rectus is moving, it can happen because the superior rectus and now to superior inferior oblique starts very far in the orbit and runs over the bottom of the roof and outside the cone. So with little inadequate volume, they have a tendency to escape. So patient gets an Bell's phenomenon. Patient keeps on rolling the eye up. In that situation, I don't submit the patient. I give additional medial block 2 to 3 ml, either medial canthus or medial peribulbar. And unless I am satisfied with the akinesia, I don't submit the patient to the surgeon.
Yes.
Number two, um, about pain. Now, usually conjunctiva require very low concentration. It usually is blocked, but it is the moment later on if by chance surgeon got a complication and surgery prolongs beyond 30-40 minutes. In that situation, this situation arises, and in that way, I have seen the movement is a hindrance more than the pain. And in that situation, sometimes surgeon give in the vicinity of the muscle also some 1 or 1.5 ml or half ml of local anesthetic and paralyze the muscle, and then later on they begin. Giving sedation is a lethal problem when patient is feeling pain, because it you cannot control patient's movement. The patient may start moving head also, and giving over sedation, you lose the control over the patient. So I don't prefer over sedation. My usual sedation is 0.5 mils of midazolam just before giving the block, giving about zero point 0.7 mic per kg fentanyl. I wait for 5 minutes and then give the block to make them comfortable for the block. And same I do continue even in the same dose during anesthesia in a slow infusion or with a top-up doses. But if patient feels pain, it is not recommended. Better to supplement the local anesthetic rather than subside it with the sedation. It's not a good technique.
Yeah. So
That question was about ultrasound. They say,
yeah.
it's a very good question. And Jai, you remember I talked about ultrasound usefulness for the blocks in Hyderabad meeting. And I think I have that presentation also.
Okay.
Just one slide I'll share.
Meanwhile, the other question is in topical anesthesia, whether there is any role for anesthesiologist or monitored anesthesia care. So
I believe you must have.
You want to share this one?
Did you see this?
Yeah.
Yes.
Yeah. This is one I am showing only one. This is still experimented. It's not very popular, but ultrasound we have two uses. First, I always get a B scan done, one for axial length, and in all myopic eyes for the staphyloma. So every myopic eyes and smaller eyeballs, I get a B scan and A scan done by the surgical or optometrist and check the report. So that is very useful for me before giving the block. Now this is very technique. So when you are giving the block, ultrasound technique is being advocated these days, and that will increase the success rate and for accuracy of the needle placement in abnormal shape of the globe, particularly in patients who have had a previous vitreoretinal surgery is done and they've done the buckling. The eyeball is a deformed. In that situation, nowadays ultrasound technology is being used. You need really expertise to use this technique. And same way, you need a very good aseptic precautions. So we have used once or twice by the tegatum placing over the probe, sterile tegatum, and try to use this. This very much helps for identification of the optic nerve. So when you are giving a retrobulbar or peribulbar, you avoid touching the nerve. So this is a new technique, which is like other regional anesthesia, is gradually picking up. So I'm very happy, and I appreciate the Dr. Raja Gopalan, he has asked this question.
Sir, whether the same linear probe is used or
no, there is no special probe available. Unfortunately, there is a research going on for a perfect probe for this purpose. Jai, you are experienced. You can tell about this.
So there are actually limitations in role of ultrasound in ophthalmic anesthesia, sir. It is mainly for academic purpose, research activity is going on. Practical purpose, USG doesn't have much role in it actually. Okay, the reason is it has to have a special probe, number one. Yeah, number one. Number two, if we see the eyelid has to be closed and the probe sometimes has to be placed, and they have to push the eyeball down towards the place where the needle is there. So, and it requires two persons assistance. Okay, cost is involved. So there are various other factors. Risk benefit, if we see, there is much more risk, little bit is involved and compared to the benefit. As Dr. Rasesh was mentioning, yes, it is useful, especially for intraocular injections into the cystic lesions. Yeah, cystic lesions are in the orbit. They give that the surgeons used to prefer that ultrasound and they give injections. Whereas for regional ophthalmic anesthesia, it is a very limited role only. Now, coming to this interesting question in topical anesthesia, whether there is any role for anesthesiologists? Yes, definitely. This is the question which In almost all the conferences, we used to have this discussion, and there is no end to it. First and foremost, topical anesthesia you should not take lightly. Preoperative evaluation and screening of the patient, choosing of the patient is very, very important. Patient's anxiety level has to be taken into account. Trial of draping should be done. Nature of cataract, whether it is a hard, soft, complicated cataract. If it is a complicated cataract or you expect some surgical complication, please don't take into topical anesthesia. It is better to go with regional. So preoperative evaluation and selection patient is very important. Now, once the patient is inside the operation theater, Dr. Rasesh was mentioning few points. Adding on to that, one more important point, under topical anesthesia, remember, patients can retain visual sensations a lot. They say compared to regional anesthesia, under topical anesthesia, more than 50% of them will retain that visual sensation, especially that microscopic light and sometimes minimal hemorrhages happening. They can even visualize the surgeon's hands and gloves. These kind of they can provoke panic attack in patients. So long back, we did a study in patients under topical anesthesia, where in one group we gave IV midazolam and in other group we gave IV placebo. And we found that patients given with IV midazolam, they were much more comfortable, satisfaction level scores were very high. So this clearly shows that anesthetist role is very important. IV line is important, monitoring is important, and especially in this current scenario of medical legal implications, anesthetist role is a must. Monitoring anesthetic care is a must, sir.
One survey, if you permit me, I want to tell,
Yeah.
I read recently, with your permission.
Yeah.
Last year in British Journal of Anesthesia, there was the article published, which was a survey done on anesthesiologists in Australia and New Zealand. That continents were selected, and the survey was how comfortable you are giving the blocks, and in and with different techniques. So 15 to 35% people, anesthesiologists in both the countries, said that they are comfortable. Rest were not comfortable, and more about 49% said we will not because we are not used to. So after that survey, recently they have started a training schedule for them, and by rotation, every postgraduate students in anesthesia has to go to ophthalmic institution for learning the blocks, because there is a tremendous demand of anesthesiologists in ophthalmology these days, because of the monitored anesthesia care. So gradually people are picking up. Maybe another 10 years down the line, we'll have all the anesthetics only giving the blocks in our country also. Like in major institutes like our place, we decide which block. No surgeon decides. VA or local, we decide. And we have a separate anesthetist OPD since 89 in our hospital. Unless anesthetist is cleared and signed, patient does not go in the list. Whether maybe cataract, maybe squint, maybe anything, vitreoretinal surgery or glaucoma surgeries. So we have made a rule. So it is whole institution is ruled by anesthesiologist only.
Okay.
Like you have Jai in your institution and Raja you have in your institution, L.V. Prasad. And same I have seen in Madurai also.
Okay.
But for only general
Sir,
anesthesia.
as you said, in Tanjavur, I was the first one to perform this retrobulbar block in the year 1996. Before that, only ophthalmologists were doing. And I have to admit, just I have seen what ophthalmologists were doing. The same thing when I went to the theater, I said, I am the anesthetist here, I will give anesthesia. I will administer. So how they are doing, I did it. At that time, I was not clear about the way in which you described.
Yes.
Now I was worried because I was just in the midpoint of the lower this thing. I have injected the retrobulbar block. At that time, we mixed with lignocaine and bupivacaine at that time. So I have injected. Now that is the reason in my specific question, what is the complication? But the way in which you say you may be having more than 25 years of experience, but you have never seen any
40.
hemorrhage. You have never seen
40.
a complication
Yes,
of hemorrhage.
yes.
More than
I've seen
25
hemorrhage.
years means it is a silver jubilee year.
Sir, can I just tell one of the complication in my life experience I had is I had a brainstem anesthesia. We have a main hospital and some periphery hospitals which are there outside in the city but outskirts. So the doctor wanted to do a therapeutic PK there, And he asked me to give the block. I gave the block, and by the time the technician came and he wanted to take patient, the patient was not responsive. So we did CPR, and very luckily we were able to revive that patient, and then we were intubated the patient. So what I am trying to tell is, it's better that even though it is a topical, anesthetist should be there in and around that area. Many of the small institutes, they say that we are doing under topical, we don't need any help. But many medical problem comes, it is very difficult for the ophthalmologists to take care of the patient. And sometimes the emergencies are so, we are seeing a lot of hypertensive crisis, pulmonary edema, even in local patients. So I feel that even the ophthalmologist should also be trained so that they can take care of the patient in that particular time.
So to sum
And
up,
we train all our ophthalmologists and everybody there in our institute.
sir, we'll sum up.
We do.
We'll sum up.
Yes.
Yeah. So to sum up, Dr. Ranjitha had a nice presentation regarding that anatomy pertinent to ophthalmic blocks. Congrats, Dr. Ranjitha. That was a nice presentation from your side.
Thank
And
you, sir.
Dr. Rasesh Diwan was mentioning about the techniques, how to go about it, each do's and don'ts. He has very clearly mentioned. So thank you, Dr. Rasesh, for the nice presentation. And Dr. Raja has elaborately measured about how to take care of patients, especially when coming to ocular trauma, not only the ocular trauma, systemic management, how to manage those patients. I think with this, we will wind up this session, sir.
Thank you,
Sir. Thank you, all the speakers, sir.
Thank you.
Yeah.
Actually, Clipnet will close the session, but it is my duty to thank you all. Before that, I want to say you are from corporate hospitals, but from the small government hospital, medical college, where the anesthetist didn't have any access to ophthalmic theatre at that time. Only for GA they will call, but even for babies, for anesthesia, they will call. But even for babies, I used to sedate and I perform peribulbar block, retrobulbar block at that time. But those were the time. Because then what I did, the post duty PG will be given 1 hour exemption. I have posted when I was the professor of anesthesia, I posted the post duty PG regularly to ophthalmic theatre, and I supply monitor. Before that, they didn't even have the pulse oximeter. So I supplied one multibar monitor to them, and one PG round every day he will go to the theatre. So that he will be exposed. So that is a small measure. Now we are arranging these webinars on that. And I thank Dr. Ranjitha, Dr. Rasesh Diwan, and Dr. Raja and Rao for the excellent description, because people should be sensitized about ophthalmic anesthesia and the complications. That is the idea. And Dr. Jay has moderated very well. He has put it in a capsule, all the three speakers, but we have to add Dr. Jay also in that box. So he has moderated, and the vast experience, everybody is experienced. The way in which they speak, it is not a theory, because he says now more than 40 years of experience, even for 25. That is the reason why we say not the years of experience, more than 25 years of experience. So I thank everyone for making this, because this is the fourth time we are reaching the 8 o'clock. Now I request Dr. Swastika to pass the concluding remarks and wind up the session.
Okay, sir.
So, thanks to all the dignitaries present here. Clarity is really glad to have all these brilliant people together in the session today. And I really hope that you all had a seamless experience. So, with everyone's permission, I'm concluding the session in here for today and looking forward to host you again. Thank you so much, everyone. Good night.
Thank you.
Thank you. Thank you so much.
Thank you.